Good morning. Welcome to the final grand rounds of this academic year. And it's my privilege to welcome to the podium this morning one of our senior residents, Gregory Burek. Dr. Burek is a graduate of Drexel University and currently will be a fourth-year resident in our program. He's also a former Marine, having actually served in Iraq, and he's an active member of the Warrior Project at the VA hospital, and we welcome him this morning to speak with us on PTSD and the review of the neurophysiology of PTSD.
Thank you. Good morning, everyone. Happy June. All right, so we're here to talk about PTSD. I like to open up with this slide because it shows some of the importance of recognizing and understanding PTSD and how it affects our patients. A couple of things to point out here. This poster came out a few years ago, published by the American Psychiatric Association. Military suicides are at their highest rate in the last 10 years, highest ever, in fact. 20% of the nation's suicides are committed by veterans, and over 300,000 have come back from Iraq and Afghanistan with PTSD. So this is the lecture, the neurophysiology. My disclosures, I'm not making any money off of this. I don't get any money from Big Pharma or anything else. Fair warning, the brain is incredibly complex. Who knew? This is basically an overview of the important parts that have to do with PTSD and the stress response. This is not an in-depth lecture. This is not a return to med school neuro class. Also, just in case anybody was wondering, I don't know it all. Again, the brain is incredibly complex. Research, we're learning things every day. This is just the data that I've collected and some of the way that I view the brain and the effects of PTSD. So our objectives today is to review the brain and body responses to stress. This is implicated in more than just PTSD. It's implicated in multiple mental health disorders, including ADHD, acute stress, panic, adjustment, even major depression, and the anxiety disorders. We also want to correlate PTSD symptoms with the neurophysiology, and then to assess some treatment strategies and their actual effects, what they're doing within the brain. This could kind of help us to match the therapy to the symptoms that the patient is suffering. So let's review the stress response. But before we get there, the purpose. So the stress response, also known as the fight or flight response, is the way that the body gets ready for action. It's engaged in response to a threat. It helps the organism to survive. The components from the brain level include the limbic lobe, the amygdala, hippocampus, the locus coeruleus, anterior cingulate cortex, and just about everything else, including the thalamus, hypothalamus, pituitary. We'll touch on a few of these areas as we go through. The body responses are translated through the sympathetic chain ganglion. We'll take a very brief look. And the adrenal glands going out, spreading out, and affecting every organ system in the body. So before we actually get started, I wanted to introduce you all to Sam. Sam's going to help us with our demonstration today. Since Sam was kind enough to show up, I got him some cookies. Why don't you go get a cookie, Sam? Oh. Okay, that was fun. So in Pavlovian terms, the bear in this case is considered the unconditioned stimuli. Bear's threatening, bear's big, bear's scary. He's going to try and eat you. So in this case, Sam's response to this is considered the unconditioned response. So let's take a look at what's going on. Bring in our little x-ray machine, zoom in a little bit. So in Sam's body right now, since he's been shocked, his heart rate is going up, blood pressure is increasing, his lungs are engaged, so increased respiratory rate and O2 delivery, increased blood flow to the muscles, decreased blood flow and motility to the GI tract. Those are some of the stress responses that happen within the body, so let's take a look at how we get there through what's going on in the brain. So the first thing that happens is the activation of the sensory areas. You see the bear, stimuli gets translated through the thalamus and goes back to the primary visual cortex. The things that tend to be more salient or more strongly viewed, paid attention to, things that are fast moving, large objects, things that are big and scary. This then spreads out to the visual associative areas. This is kind of where you recognize what the thing is, what it's doing. This is where you start to form the image. That's probably not the last time that's going to happen. So with the bear's roar, you hear it. Again, it goes up to the thalamus, hits the primary auditory cortex. This tends to be signaled more strongly through loud noises, high frequencies. Again, things that are salient, things that are threatening, those are the things you tend to pay attention to. From there, it spreads out to the auditory association areas and to the rest of the associative areas in the brain. You can think of some of these areas as where the memories are held. So some of the primary processing, this is where you associate the bear's growl to the fact that it's threatening to other situations in your life that may have been traumatic. So once you access those accessory areas in the memories, those stimuli get moved up to the frontal lobe. This is where you can make decisions, plan how you're going to react, decide what you're going to do. In the ADHD literature, which I'm borrowing from just a little bit, this is called salience or bottom-up attention. It's when the stimuli is more salient, it's stronger stimuli, it tends to move from the associative areas up forward to the frontal lobe. This is basically the louder or the bigger something is, the more attention you're going to pay to it. So let's talk specifically about the frontal lobe and the prefrontal cortex. It's primarily inhibitory. It basically shuts down or filters out stuff from other areas of the brain. It helps to regulate attention by suppressing function within the parietal and temporal associative areas. This is that filtering, so you don't have to pay attention to every squirrel that jumps or every noise that goes off. It also can do work on the subcortical area. So your eyes tend to move to fast-moving objects, your ears tend to pay attention to loud noises. This is a way of suppressing that so that you can pay attention to talking. It also regulates behavior, in this case motor behavior, by interacting with both the premotor and the motor areas. Also subcortical structures. It impacts the caudate and the cerebellum, coordination, decisions on how to move. It also helps us to regulate our emotions. So the frontal lobe, prefrontal cortex can help to inhibit the amygdala, the hypothalamus, the nucleus accumbens, the brainstem. Again, this is a way that you don't have to feel and react to everything that jumps into your mind. Can also access memories. In dynamic terms, this is making the preconscious conscious. So something that you're not thinking about yet, you can decide to think about it. You can decide to bring back a memory. This is generally done by accessing those sensory associative areas. That's kind of thought of as where we hold semantic and episodic memory. You can access the cingulate cortex, which is a little deeper, but that tends to be our emotional memory per se. This is where, if you have a traumatic experience, both the emotion and the memory of the traumatic event are going to be held. So the frontal lobe tries to push that back. This is known as suppression. So the voluntary inhibition of those memories, of those impulses, desires, emotions, the frontal lobe helps us to suppress. Again, in the ADHD literature, this is known as top-down processing or top-down attention. It's when you decide what to focus on. It's when you filter out the things that are not important. The problem with this process is that it's very slow. And in this case, it leads to Sam getting eaten. So there's also another way of processing on the subcortical level. It all starts in the thalamus, and as we saw before, the thalamus functions as the hub for sensory and motor information in the brain. almost every part of the brain goes through the thalamus in one way or another. It's kind of a way of connecting the different brain regions together. The inputs. Okay, I think that's the last time. The inputs tend to come from the sensory areas. This is one way into the thalamus. That visual stimuli come through that little red dot called the lateral geniculate nucleus. The auditory stimuli come through the medial geniculate nucleus. You don't have to remember any of these minor parts, putting them in there for reference. The important part is that all the sensory information goes through the thalamus. The thalamus also has effects. The thalamus also gets affected by the amygdala, the caudate, and the prefrontal cortex. The amygdala tends to jazz up the stimuli that's coming through and switch you from more of that top down to the bottom up processing or attention. The frontal cortex tends to suppress a lot of that, allowing you to filter and focus on what you want to. So the thalamus goes everywhere, but the important parts for this lecture are the thalamus has direct connections to the prefrontal cortex and also to the amygdala. So let's move on and talk about the amygdala. This is one of the key points of the lecture. The amygdala is kind of the seat of fear and anger for the brain, and it acts as a type of a smoke alarm. So you smell smoke, there may be fire. This is the brain sending off a warning that there may be something threatening or something wrong in your environment. The inputs tend to come from the thalamus. So we talked about those sensory areas into the thalamus. This is how those sensory inputs get to the amygdala. The prefrontal cortex is connected to the amygdala, as we said before, and can actually suppress that smoke alarm. And then it's also connected directly to the anterior cingulate cortex. So think of those emotional memories. You have an emotional event, and the amygdala gets charged up via the thalamus, via the anterior cingulate cortex. The outputs tend to be all over the brain. Again, as the smoke alarm, it wants to get you ready for action. So here's a few that we listed. The dorsomedial thalamus. This has to do with the processing of pain, attention, and memory. The hypothalamus, we're all familiar with the HPA axis. Hypothalamus, pituitary, adrenals. This is how the body gets activated through cortisol and epinephrine. We'll go through that in a little bit. The hippocampus gets directly activated by the amygdala. And this is important when it comes to traumatic memories, because the hippocampus is where we consolidate memory. The amygdala gets charged up and activates that area so that anything traumatic tends to be very finely, vividly detailed in our memories. So the more active the amygdala, the more active and the more effective the hippocampus is going to be for consolidating memories. Also the ventral tegmental area, this little purple dot here, which is one of the seats of dopamine in the brain, and the locus coeruleus, which increases norepinephrine. This is one thing that I wanted to talk about, these direct connections between the amygdala and specifically the ventral medial prefrontal cortex, or we'll just say the prefrontal cortex or the orbital frontal cortex. You can think of this as a type of a balance in the brain. So this is your balance between your reactive side, whether you're just going to act on instinct or whether you can be rational and think through your decisions. They both reciprocally inhibit each other. So the frontal lobe can suppress the amygdala. The amygdala can in turn suppress the frontal lobe. When the amygdala is winning, when you have more output from the amygdala, you tend to suppress that prefrontal cortex. You move into that fight or flight type of mode. You get less inhibition, so you get less voluntary action. You get more instinctual action, more reactive type behavior. This balance can also go in the other direction. The more you activate that prefrontal cortex, that thinking part of the brain, the more you're going to suppress the amygdala, the more inhibition of those reactive behaviors you're going to get, and the more choice you have in decision in what action you're going to take. The amygdala also activates the hypothalamus. Other inputs come from the nucleus of the solitary tract and the locus coeruleus. The output of the hypothalamus, again, all over the brain, but the specific tracts we want to talk about are the ventrolateral medial nucleus, or the ventrolateral medial part, medulla of the hypothalamus. This is directly connected to the sympathetic chain ganglion. That's brain to body. Hypothalamus activates this area. It spreads down the spinal cord, releases norepinephrine or epinephrine everywhere, and becomes the whole body response. Another important area, at least in the research right now, is the lateral nucleus, which releases orexin. Orexin hits a lot of different places, especially within the brainstem. So it tends to modulate things like the raphe nuclei, the locus coeruleus, other areas. It modulates the release of other neurochemicals within the brain. The tuberomammillary nucleus releases histamine, and this has a lot to do with our arousal system. You can see by the yellow arrows here that it spreads throughout the brain, cerebellum, brainstem, and it affects things like cognition, memory, muscle movements. It affects the reward pathway and affects the hypothalamus directly, increasing arousal. The other place we can go from the hypothalamus is down to the pituitary. Specifically, the posterior pituitary is just an extension. It's the end of the axons from the hypothalamus, releases oxytocin, releases vasopressin. These tend to be released more in times of stress. It's part of the stress response. But the anterior pituitary actually releases corticotropin-releasing hormone. This goes down to the pituitary and causes the release of ACTH. This is another connection between the brain and the body. When the pituitary releases ACTH, it travels down to the adrenal cortex, releases glucocorticoids, specifically cortisol, known as the stress hormone. That stress hormone causes the whole body to increase blood glucose, decrease inflammation, decrease the immune response. This is thought of as part of the body's stress response. Again, more sugar, get ready to take more action, and then decrease inflammation and immune function to kind of get through what you need to get through before you get back to healing. Another part affected by the amygdala and by the hypothalamus is the locus coeruleus. This is actually the place where a majority of your norepinephrine outflows from. It takes its input from the orbital frontal cortex, prefrontal cortex. It also takes input from our autonomic areas within the brainstem. So your heart rate goes up, you release more norepinephrine, whatever the case. Also from the lateral hypothalamus. These connections go all over the brain as well. When you're thinking of a fight or flight response, norepinephrine gets released. It goes to the entire cortex, increasing cognition, increasing arousal and vigilance. It hits the amygdala, the hippocampus, the cerebellum, brainstem, spinal cord. It goes everywhere because you want your fight or flight response to be quick and all-encompassing. You want the whole body, the whole organism to take direction and to move quickly. It also goes back to the thalamus. It engages the hypothalamus pituitary adrenal axis, increasing cortisol, increasing epinephrine. It hits the tectum, which is the part of your brain that decides what you're going to look at. So increased norepinephrine means your eyes are more reactionary. It's harder to suppress that looking at something fast-moving, something threatening, or paying attention to those more salient things. It also hits the ventral tegmental area. So let's talk just briefly about the VTA. This is one of the reward systems in the brain. Primarily, it releases dopamine, takes input from the amygdala, from the cingulate cortex, from the hypothalamus, from the prefrontal cortex. just to take a quick pause. You see how everything is kind of interconnected? It's hard to tease apart a lot of these pathways, because for every pathway going out, there's another one coming in. But again, we're focusing on the things that are more important for the PTSD pathway. The outputs from the ventral tegmental area, one of the specific ones is known as the mesocortical pathway. Any of you treat people with psychotic disorders and use antipsychotics are familiar with this pathway. Dopamine released to the frontal cortex increases concentration, attention, cognition. So blocking that pathway, you tend to get that kind of that dull face and the dull cognitions that sometimes you can see in somebody with like chronic schizophrenia. The VTA also outputs to the mesolimbic area. This is dopamine to the limbic lobe. So it connects with the nucleus accumbens, which is the seat of reward within the brain. It affects reward, pleasure, wanting, affects your motivations. It also affects your thinking and your learning. So the bigger the reward, the more likely you are to seek it, and the more likely you are to remember it. And this becomes important in the avoidance symptoms, because getting rid of the stress or avoiding the stress actually causes a release within the VTA, releasing dopamine and causing a reward inherently by the stimulant. Just for completeness, I wanted to talk about the Raphe nuclei. There's actually 6 of these. I'm only showing one at this point. These are the areas of the brain that tend to release serotonin. It takes its input primarily from the orbital frontal cortex, just like every other nuclei. The cingulate cortex, the hypothalamus, specifically the medial and lateral preoptic areas. And it outputs primarily to the cortex. These 3 nuclei are the rostral nuclei, the ones that are a little higher up in the brainstem, so they tend to go up. They affect the cerebral cortex. 10% of the output of these nuclei go to the amygdala and are actually inhibitory. They also go to the caudate and putamen, so have a little bit to do with voluntary movements. The more caudal nuclei, the ones that are down more in the brainstem, they release out to the body, the brainstem and the spinal cord. So 90% of serotonin has its actions within the GI tract, and that has a lot to do with the caudal nuclei. So I wonder if that has a lot to do with the side effects that we tend to notice: nausea, vomiting, diarrhea. Let's just take a really brief review of how a neuron works. On the postsynaptic side, these are the postsynaptic receptors. They activate the next neuron downstream. There's presynaptic reuptake receptors. This is where SSRIs and SNRIs work. There's also presynaptic autoreceptors. So think you release neurochemical, some of it hits this neuron, or some of it hits this receptor, and it turns down some of the firing on the presynaptic side. So here we activate the neuron, release of the neurochemical. Some of the neurochemical hits those postsynaptic receptors and activates the next neuron. As this neuron becomes more active, the more times you activate, the bigger it grows, and the more easily it becomes activated in the future. One way of getting rid of extra neurochemical is through that reuptake receptor. It gets pulled back into the presynaptic neuron, gets repackaged into those vesicles for use again. Another way is to attach to the presynaptic autoreceptors. When it attaches to those receptors, it's going to decrease firing of the presynaptic neuron. So this is kind of a feedback mechanism to let the presynaptic side know that it's already released enough neurochemical, it can back off. Another way to get rid of the excess neurochemicals is for it to diffuse out into the cerebrospinal fluid. So that of these, that when these neurochemicals diffuse out into the cerebrospinal fluid, they tend to form a baseline, kind of a basal level within the cerebrospinal fluid, and whichever neurochemical it is, it makes it easier to fire that kind of neuron. think of norepinephrine. If you have a lot of norepinephrine in your cerebrospinal fluid, it makes it easier to activate other neurons that are dependent on norepinephrine. So this chart shows the abilities within the prefrontal cortex, and again, this is borrowed from the ADHD literature. And this is compared to the levels of catecholamine that are available. The idea is, if you have too little norepinephrine and dopamine in the brain and the cerebrospinal fluid, you'll feel fatigued, you won't be able to pay attention, you won't be able to focus on anything. You have a moderate amount and you're awake, alert, you're able to pay attention. You have too much, you tend to go into that more fight or flight or stressed out mode, where you start to lose your focus, you get distracted, you get disorganized and impulsive. We can correlate this to a kind of a stress meter, and I'll use this stress meter throughout the rest of the lecture. Good for us. Less norepinephrine in this case, less stress. More norepinephrine in the cerebrospinal fluid, more stress. Does that make sense? All right. So let's all take a deep breath. That little neuroscience review is over. Now let's talk about PTSD. For this part, I brought Sam back in. Similar situation. Sam is thinking about the bear, so his stress level is already up. It's not in the green anymore. Now it's in the yellow. He's kind of ready. He's waiting for something to happen. Taking a walk just like he did before. This time the cookies come up. The cookies make him think of the bear and cause that same stress response to go off. So in this case, his thought of the bear or the bear itself was the unconditioned stimuli. The cookies now, reminding him of the bear, become the conditioned stimuli, and his stress response is the conditioned response. So let's take a look at what's going on in the brain for the conditioned response. Sees the cookies, it spreads to the thalamus, it alerts the amygdala, that smoke alarm, releases norepinephrine throughout the brain and body, activates the hypothalamus, increasing that whole arousal system, moving down to the pituitary releases ACTH. That affects the adrenals release cortisol and epinephrine. This increases that heart rate and blood pressure, increases respiratory rate, blood flow to muscles, decreased blood flow and motility of the GI tract. This is your fight or flight response. So in this case, just the cookies being the conditioned stimuli could affect the entire body. Talking about PTSD, I listed the criteria. I'm not going to read them off for you, but exposure is a critical part of this. So think about where Sam was when the bear first growled at him. That engaged this fight or flight response. And that's part of what we're talking about with exposure. You need to engage that response in order to get to PTSD. In this case, the man with the knife, it activates the whole fight or flight mechanism, and it gets kind of locked in the brain through that amygdala to hippocampus connection. So let's talk about intrusive symptoms. These are intrusive memories, distressing dreams or nightmares, flashbacks, physiologic distress at the exposure, or physiologic reactions to cues. So this was a cool study. They took 11 or 12 people with PTSD and gave them a chemical called yohimbine. It actually causes a massive release of norepinephrine in the brain and body, and they kind of surveyed what happened. So what happened with the folks with PTSD, the ones that received yohimbine, you can see that their fight or flight response went through the roof. Their PTSD symptoms, and specifically those intrusive symptoms, also went through the roof. The ones that received placebo had almost no effect, no reaction, no change from the baseline. So in this case, the yohimbine causes this massive release of norepinephrine and sends our stress meter into red. This is from the same study. I wanted to include this because panic or feelings of panic are akin to that fight or flight response. In this case, they tracked people for panic symptoms as well, surveyed them for panic symptoms as well. You can see two things in this slide. For one thing, the clear or the open dots, the circles are patients without PTSD who receive placebo. The open squares are people without PTSD who received Yohimbe. So they still had a massive release of norepinephrine, but they didn't hit threshold for PTSD symptoms. The dark squares are the folks with PTSD who received placebo. So you can see that they kind of stayed right around their baseline. If anything, they dropped a little bit. Those with the dark circles are the patients with PTSD who received Yohimbe. So what you can see here is you have a much more massive release of norepinephrine correlated with PTSD symptoms in those who already had PTSD and received Yohimbe. I like this slide and I like this study because nightmares are a big deal in PTSD. It's one of the cardinal symptoms. Those distressing dreams are actually blocked by a chemical called prazosin. Most of us are familiar with it. What it does is it blocks that postsynaptic receptor so that the norepinephrine can't have any effect downstream. It blocks the norepinephrine effects. And in the case of this study, it actually showed that you block the norepinephrine, you block the nightmares. This was another interesting study. They took a bunch of PTSD patients and they actually monitored the norepinephrine in their cerebrospinal fluid. So they took a spinal tap and left it in and monitored them over the course of time. They showed them two types of movies. One was a neutral movie, just kind of something to watch, something that shouldn't be overly emotional. The other movie was trauma-associated, trauma-related. So you can see that the open circles are the ones who saw the neutral movie. And again, they stayed pretty close to their baseline. Maybe there was a little excitement in the movie, but nothing that really sent them into that fight or flight mode. Of the dark dots, you can see that it takes a spike towards the end of the movie. These were the patients who watched the trauma-related movie, and you can see the direct increase in the norepinephrine within their cerebrospinal fluid. I wanted to skip ahead to the criterion A because it'll make sense when we get into it. These are the arousal and reactivity kind of symptoms. Irritable behavior, angry outbursts, hypervigilance, startle, poor concentration, and sleep disturbance. This is a little different than the sleep disturbance from the distressing dreams. Even though nightmares can wake you up, this criteria is talking more about difficulty falling asleep or difficulty staying asleep. So disruption of the sleep cycle. These symptoms were also correlated with norepinephrine levels within the cerebrospinal fluid. Again, they took patients, they did spinal taps, they saw what their levels were. And you can see at baseline, without any traumatic stimuli or anything engaging their fight or flight mechanism, they stay at higher levels of norepinephrine throughout the day. This correlated, the second graph that's up there, correlated well with the severity of the symptoms. So the higher the norepinephrine, the worse the PTSD symptoms. So think about the bear. That causes massive release of norepinephrine. Makes it the norepinephrine that's already baseline within the cerebrospinal fluid makes it easier to think about the bear, which tends to throw you back into fight or flight mode. And again, just for fun, that's the pathway that's going on in the brain. I wanted to take just a minute to talk about sleep. Again, we're not going back to a med school lecture or undergrad lecture. But 4 stages of non-REM sleep. Stage 1 is kind of you're drifting off to sleep, but you're kind of still awake. 2, you are asleep. 3 and 4, you're in deep sleep or slow wave sleep is what it tends to be called. These kind of change throughout the night. You tend to start up at 1, go down into stage 4. REM periods are kind of interspersed, so that rapid eye movement, that dreaming type of sleep is interspersed throughout the night. But then something kind of rouses you into stage 1 or stage 2 when you go back down. The reason that sleep is so important is because it changes in PTSD, and there's a lot of things that affect it. So for one thing, in PTSD, you tend to have increased latency. It's harder to fall asleep. It takes you longer. You're lying in bed, your mind is racing. You just can't drift off. You can't shut it off. You also have an increased number of awakenings. And the reason that awakenings are so disruptive is because once you wake up, you have to start back in stage 1. And it takes time to get back down into the deep stages of sleep. So this decreases total sleep overall. Some studies showed upwards of an hour less sleep just based on the diagnosis of PTSD. And decreased sleep efficiency. So think more time awake, more time in stage 1, less time in those deep stages of sleep. As I just said, it decreases the amount of slow wave sleep that you get. It actually decreases REM latency. So this is similar to in sleep deprivation or in depression. You tend to go into dreaming a lot quicker than usual. Most people believe it takes about an hour-ish to get into your first REM period. These people can go straight into REM within 10 minutes, within half an hour, causing you to have a dream, sometimes a nightmare, and then waking up again. You also have an increased amount of REM sleep and increased REM density. Correlating back to the nightmare thing, this is often a huge disruption in PTSD. You go to sleep, you have a dream, your fight or flight mode is already active, so that dream actually becomes a nightmare. You take that fight or flight with you into the dream. That wakes you up. You're already aroused when you wake up, so your heart's racing, you have to take a deep breath, you have to settle yourself down. So it takes time to get back to sleep. This can last an hour, 2 hours for some patients. Some patients aren't able to get back to bed at all. So again, let's look at the neuron, but let's talk about a neuron in sleep deprivation. The neuron fires, you release neurochemical, that activates the next neuron down the road. Some of the neurochemical goes through the reuptake channel and gets repackaged into vesicles, some of it diffuses out. The problem is that it takes the neuron time to grow more vesicles and to produce more neurochemical. So this time the neuron fires, maybe before it's prepared to. It releases neurochemical, but less. This time, because there's less, you get the next neuron may or may not be activated. It makes it harder to trigger the postsynaptic neuron, and eventually this presynaptic neuron can be completely depleted of neurochemical. So the importance of slow wave sleep is it's the only time while you're sleeping that your brain slows down enough for these neurons to catch up and replenish their vesicles with the needed neurochemical. Disrupt slow wave sleep, deep sleep, and you'll prevent the neuron from actually recovering. So then it's going to be harder to function the next day. So I wanted to show kind of the baseline level of all of the neurochemicals. Well, these three, and their correlation with the stress response. So when you're well rested, your norepinephrine tends to be lower. Serotonin and dopamine tend to be in full store, so you can have an active and engaging and fun day. When you're sleep deprived, the opposite is true. You deplete your norepinephrine, you deplete your serotonin, you deplete your dopamine, norepinephrine and epinephrine, adrenaline, go through the roof. It's the only thing keeping you awake at that point. So when your norepinephrine is that high and your other neurochemicals are low, it means that you spend most of the day at that threshold, at that irritable, reactive, kind of not feeling good about anything. You're cranky throughout the day. It's not going to be a good day. Next, let's just talk briefly about avoidance symptoms. As I had mentioned before, brain releases dopamine for a reward. When you engage in an avoidance behavior, when you remove yourself from a stress, it actually releases inhibition on that part of the brain, gives you a little squirt of dopamine, and serves as a reward. So in this sense, this is why people cling to their avoidance behaviors, because they're actually getting a physiologic reward whenever they avoid or eliminate a stressor. Negative symptoms. These are important. And they also look a lot like depression, don't they? Trouble with memory, negative beliefs, distorted cognitions. There's a lot of blame, self-blame that goes on. diminished interest in participation, detachment, inability to experience positive emotions. These symptoms also can be correlated with serotonin and dopamine levels. So when you don't have serotonin and dopamine, you can't concentrate. You don't feel good about anything, so a lot of negative feelings, negative beliefs. Your brain's not working as well, specifically the cortex, so you tend to get a lot of distorted cognitions, diminished interest, detachment, and ability to experience positive emotions. Just for completeness, post-traumatic stress as opposed to acute stress needs to be at least 1 month in duration, clinically significant as with anything else, and not due to substance abuse or medical condition, though substance abuse is often comorbid with PTSD. The reason that we talk about more than 1 month is because it actually leads to changes in the brain. So these are some of the changes in the brain that occur with chronic PTSD as compared to changes in the brain with other anxiety disorders. You can see here that in post-traumatic stress, the amygdala hypertrophies. It gets bigger, gets more active, gets easier to activate. So think more smoke alarm more often. Also, this anterior cingulate cortex, which tends to be one of the links between the prefrontal cortex, the inhibitory part, and the amygdala, that part shrinks. So, more difficult time to inhibit, to push back and suppress those warning signals. The hippocampus, depends on the study that you look, initially gets bigger because of the activity of the amygdala, but eventually, especially with the influence of cortisol and other glucocorticoids, it gets smaller. So it'll get smaller in the brain after years to decades of PTSD, of increased cortisol levels. It makes it harder to remember new stimuli, makes it harder to get rid of the old stuff too, to change those memories and cognition. All these chronic changes tip the balance in favor of the amygdala, tip the balance in favor of that irrational, reactive type behavior, that fighter. Another deep breath. Let's talk just a little bit about treatment. There's medication treatments, there's also therapies. The whole idea is to tip this balance in favor of that prefrontal cortex, that rational mind, that feeling good compared to the fight or flight. The first medications, and the only ones that are actually FDA approved for the treatment of PTSD, are SSRIs. So think sertraline and Paxil, escitalopram, citalopram. What are they doing in the brain? What are they doing for somebody with PTSD? They're releasing norepinephrine, mostly in those cortical areas. Most studies have shown that serotonin, even though it does have excitatory and inhibitory properties, depending on which receptor it hits, a majority of it is inhibitory. So think boosting frontal lobe activity. It makes your major inhibitor better at it. This tends to bring down that stress level. Decreases firing within the amygdala, increases cortical functioning, increases prefrontal cortex, tipping the balance in favor of the rational mind. We can also talk about blood pressure medications that we brought up before. This is that norepinephrine response. These blood pressure medications specifically block that norepinephrine response. Prazosin blocks it at the postsynaptic receptor, so norepinephrine still gets released. It just doesn't have the effects because they're blocking where it's supposed to be attaching. This decreases the effects of norepinephrine throughout the brain. It brings down that stress response. It brings down that fight or flight. Clonidine and guanfacine attach to that feedback receptor, the presynaptic receptor, and they actually prevent the release of norepinephrine. So this can actually bring down those baseline levels of norepinephrine within the cerebrospinal fluid. Overall, brings down the stress response, brings down that baseline, tips the scale in favor of the prefrontal cortex and away from the amygdala. Antipsychotics. They get used way too much. Use them with caution. For one thing, they block dopamine, specifically in that mesocortical pathway. So they're going to decrease attention, decrease concentration, and decrease cognition. You're shutting down parts of their brain. The benefits of something like quetiapine, like one of the next generation, second generation antipsychotics, is that by blocking dopamine, you're actually blocking REM sleep. So if somebody has terrible nightmares that are refractory to anything else, this will decrease the amount of REM sleep they get. May in fact get better sleep because less awakenings due to nightmares. If a lot of the second generations also have alpha-1 activity, so similar to that prazosin, they will block the norepinephrine at the receptor. So this is some of the anxiolytic effect that you see from second-gen antipsychotics. These might tip the balance a little bit in favor of the balance away from the amygdala, but again, just use with caution. These are way down the line, way down the algorithm of what to use. Benzos, don't use them. Don't use them at all. Not in PTSD. There's many effects. So benzos increase the amount of GABA within the whole brain, but more so in the prefrontal cortex than it does in the subcortical regions. So what you're doing is you're decreasing the memory, you're decreasing attention, cognition, concentration. You're actually blocking slow wave sleep. Benzos and alcohol reduce the amount of stage 3 and 4 that you get. So even though you may be sleeping more, it may be easier to fall asleep, you're going to get that less restorative sleep. You're not going to be able to replenish the vesicles you need to have a functional day tomorrow. They also tend to be disinhibiting, and they do in fact interfere with the therapy. So please do not use benzos for an extended period of time in PTSD. These will tip the balance towards the amygdala, towards reactivity, impulsivity. Let's talk just a little bit about the therapies, because the therapies are the number one treatment. Prolonged exposure therapy, just in brief, is repetitive recounting of the trauma in different ways to kind of engage some of that fight or flight response, but in a controlled and safe environment. You can use visual, tactile, auditory cues in kind of a gradual progression. So like other types of exposure therapy, ramp up the amount of emotion, the amount of affect that you're going to get. Through repeated stimulation, that memory, that traumatic memory, gets habituated, or you get desensitized to it. So what this is going to do is it's going to reduce that subcortical response, that fight or flight whole body response, when you think about the traumatic event. This can decrease avoidance directly because you're actually putting the veteran and putting the person with PTSD in the situation that they're avoiding, decreases avoidance. And the changes that occur in the brain are decreased amygdala activity, increased dorsal anterior cingulate cortex activity, and increased prefrontal lobe activity. Again, tip the balance away from the amygdala and towards that rational part of the mind. Another mainstay of therapy is cognitive behavioral therapy. There's a variation of this called cognitive processing therapy. This is basically when you're questioning some of those dysfunctional thoughts, the consequences, the self-blame, things like that. It also decreases avoidance because you're talking about the trauma, you're talking about your triggers, you're talking about all of those things that create that strong affect. This tends to reorganize the memories within the brain. Every time you access a memory, it's not like going on your computer and clicking on a file. Every time you access a memory in your brain, you change it just a little bit. So by activating memories in a safe environment and talking about the way that you think about them, you're actually changing the memory. This leads to a decreased amygdala, increased prefrontal lobe. You're increasing or improving that top-down attention, that frontal lobe control of what you're feeling, increases anterior cingulate cortex firing, and increases hippocampal activity. So by engaging in these thoughts, engaging in the emotion and the affect of the trauma, you are turning on the hippocampus, making it easier for you to change the memory or change the feeling of the memory. Eye movement desensitization, reprogramming, Similar to the other two, in this case you're talking about the trauma. You tend to have a script that you talk through. You talk about the disturbing images and the memories, interrupted by these saccade eye movements. So you're kind of trying to engage some of the REM, those sleep dream mechanisms within the brain. The idea is that you get stuck in a memory and you try to process that every night during REM sleep. But the nightmare wakes you up, so you never get to the point where you can fully process it. By using this method, you tend to get through that dream only while you're awake. And you get to that confrontation, so you decrease the avoidance of the stimuli, and it leads to, through getting through the traumatic story, you tend to decrease the amount of fear, the amount of affect that comes with it. This is also shown to decrease amygdala functioning, increase frontal cortex, frontal lobe activity, and improve that top-down type of model. So all the therapies are decreasing amygdala response, increasing frontal lobe. These are just some of the changes that you can see on imaging, specifically functional MRI. On the left side, you see the changes in the brain. For example, the decreased size of the amygdala, increased size of the hippocampus, increased size of the anterior cingulate cortex. On the right side, you actually see positive and negative predictive factors based on imaging for how somebody is going to respond to therapy. If they have increased prefrontal cortex function at the baseline, that's a good sign. They can think about something, they're probably going to be responsive to therapy. If they have increased amygdala activity, specifically to neutral stimuli, so somebody who's reactive to their trauma is expected. But if they're less reactive to a neutral stimuli, that's a good sign. If they're reactive to both their trauma and to neutral stimuli, that's actually a warning sign, and they may be one of the ones who won't respond very well to therapy right now. So with that, let's go back to the bear. I wonder where Sam is. Does anyone have any questions? Sure.
How can we access the PowerPoint for this?
Oh, did you like some of that?
I did.
Okay, the question is, how do we access the PowerPoint? But I can make some of it available to you all. Okay? Yes, sir.
This might be construed as a feeder question or a planted question, but
Yeah.
I know your fondness for trazodone. I'm surprised that. Can you say a little bit about how trazodone might be helpful?
Certainly. Completely separate lecture, but each medication, each sleep medication or otherwise, has different effects on different stages of sleep. Most sleep medications, just in brief, the benzodiazepines decrease the amount of deep sleep you get, also suppress REM. Things like Ambien, the more selective benzoreceptor sleep medications, are kind of on the fence. They haven't shown to affect deep sleep, REM sleep, as much, but it's kind of patient dependent too, and dose dependent. Trazodone specifically is one of the medications you can use for sleep that's been shown to increase the amount of deep sleep that you get. So it's one of my go-tos. And it also has some alpha-1 activity. So it'll also block some of that norepinephrine and help to block the nightmares while you're sleeping. It's one of my go-tos. Thank you.
So each time, I don't know about everybody else, but each time I heard the bear roaring, I had a brief moment of startle and fear, and then I remembered it was a sound effect, and I was okay. What is the, I guess, neurologic underpinning of how I categorize it as not a threat?
Good question. Jeremy asked that. He said when he first heard the bear, he felt that kind of arousal, but then realized it was just a sound effect and was able to calm himself down. That's the difference in timing between that subcortical pathway, that arousal that's kind of preconscious or subtle, that's kind of preconscious or subconscious, and the cognitive pathway. It took a longer time for the stimuli to get to your cortex than it did to engage your fight or flight. So once the stimuli got to those cortical areas and to the frontal lobe was able to push back on the amygdala and shut down.
Kind of leading off of that, are you aware of anything that the military is doing to train people to have that more cortical rather than subcortical response? Like in active duty, is there some kind of exposure or preparation that people go through to?
That's called boot camp. So the question was, am I aware of anything that the military is doing in order to boost that kind of cortical functioning, the ability to think about things and suppress things, compared to just activating a fight or flight response? The things that you go through in boot camp are meant to engage that fight or flight response, again, in kind of to get you used to feeling that way. This way, they can replace some of those instinctual responses, run away, fight, whatever, with the trained responses of do your job, accomplish the mission, whatever. So most of boot camp is actually a lesson in suppression, sleep deprivation, food deprivation, chronic stress. Frontal lobe gets bigger, pushing all that back. Good question. Yeah.
So when these numbers say that that's not working,
You're right. Absolutely. We haven't thought about these cortical pathways. We haven't thought about that when it comes to the training of our veterans. So at this point, we are not preparing our veterans, our troops well for that chronic and prolonged stress, not to mention the acute traumatic incidents. We are starting to do debriefing and using some of these kind of built-in brief therapy type windows, but there's still a lot of stigma against mental illness within the military itself. Dr. Jim.
Can you comment on the role of mindfulness meditation in the therapeutic regimen?
Absolutely. It's huge, and it was actually included in the cognitive behavioral therapy. I didn't list it out separately. But what that is you engage in that fight or flight. You get that fight or flight response. Sorry, the question was any idea about what meditation does or its role in the therapy. So everybody's engaging that fight or flight response in PTSD, and through meditation, you get grounding, you get more frontal lobe and more cortical activity to push back on that feeling. So the more you engage in mindfulness, the more active the frontal lobe is, the less active those subcortical regions are. Yes, sir.
So I would argue what you described here is some of the ties that bind an otherwise heterogeneous group of PTSD.
Absolutely.
So to that end, one of the other ties that binds it is the experience of helplessness at the time of trauma. Can you speak to how that fits into the pathogen, but also the treatment?
That is a really, really important part. The question was, could I speak on how feelings of helplessness during the traumatic episode impact these cortical and subcortical pathways? One of the big risk factors for things like PTSD or to consider something traumatic is that feeling of loss of control. You're helpless. You have no ability to control yourself or what's going on around. Some would argue that that's in fact what makes things traumatic. So somebody can go through the same series of events, combat in Iraq, whatever. Some people don't get that feeling of helplessness. So their stress response tends to stay in that acute stress phase if they have symptomatic at all, and then decrease over time. They regain their feelings of control over their environment around them. The people that develop PTSD tend to have one or several incidents where they feel completely out of control, and it throws their perspective of the world around them off to the point where they cannot recover in that period, and they start to develop PTSD symptoms. Thank you.
We're going to certainly have more questions, and they'll be available to the students. I think I've seen reference to the fact that there are sort of subtypes of PTSD, and that the veterans who have chronic exposure to trauma is a little bit different and more resistant to treatment than a single episode of say, a motor vehicle accident or a bear chasing you in the woods. but that it has some effect as well, because if you think about it, the soldiers that are there every day, under that stressful situation, so they're constantly traumatized.
And multiple traumas.
Multiple traumas. So with that, again, thank you very much for a very informative presentation.
Thank you.